Thank you. Good morning, good afternoon, good evening, wherever you are, and welcome to the second WHO and TechNet webinar series on why gender matters for immunization. The session today is about empower and collaborate with civil society and change agents to overcome gender barriers. You can listen to this session in French. To do so, please click the globe icon at the bottom of your Zoom window and select the language in which you'd like to listen to this session, English or French. By default, it's in English. And now in French for our francophone audience. Vous pouvez écouter cette session en français. Pour ce faire, cliquez sur l'icône en forme de globe et sélectionnez la langue dans laquelle vous souhaitez écouter cette session. L'icône se trouve en bas de votre fenêtre Zoom. We also started the introduction of a concept quite new for TechNet webinars. So you can now watch the slides in French. To do so, click on View option at the top of your window. If you want to watch in English, which is normally by default, select Michaela. And if you want to watch in French, then select Stephanie. I'm going to say that in French again for the Francophone audience. Vous pouvez aussi voir les slides, les présentations en français, le visuel. Pour cela, en haut de votre fenêtre, vous devriez avoir un bouton qui permet de choisir l'option et donc de regarder les slides en français. Donc, ce bouton s'appelle View Option en anglais ou option d'affichage en français. Vous pouvez ensuite sélectionner Michaela pour regarder en anglais ou Stéphanie pour regarder les slides en français. We'd be happy to know who's with us today, so you can already introduce yourselves in the chat box and select and tell us your name and where you're from. You can also use the chat box if you have any technical issue. I'll do my best to help you. If you have any question during the presentation, please use the Q&A box. The Q&A box is available at the bottom of your Zoom window as well. You can ask your questions at any time. Our panelists will answer them in writing when they can, or they will be answered after the presentation during the Q&A session. Finally, this session is recorded as per usual, and we'll share with you the links to the video as well as the slides by email. I hope you'll enjoy this session, and I'll give the floor to Stephanie.
Thank you, Alex. And Michaela, maybe we can move right into the second slide. Welcome, everybody. Welcome to the second webinar in our second webinar series based on the Why Gender Matters for IA 2030 guidance document. I hope by now everyone's very familiar with this guidance document, and I hope by now actually many of the people on this webinar were able to attend our first webinar series and also our first webinar 1 month ago in this second round of webinars. If you weren't or if you've missed some, everything is available on our TechNet page. The link is there. The link will be provided again at the end of this presentation and in the chat as well. So if you want to go back and review a specific topic that you missed, please do, and feel free to share this around as well. We have 3 more webinars following this one. You're automatically all registered if you are here today, so you'll get a reminder about that. But of course, do continue to share this around with your networks and encourage colleagues to sign up for the upcoming webinars. We still have 3 more in this series. So next slide, please. So today's webinar topic is going to focus on one of the gender responsive approaches to increasing immunization coverage as highlighted in the Why Gender Matters guide. Specifically, we're focusing today on empowering and collaborating with civil society and change agents. We'll have 2 different presentations today and 4 guest speakers. So we have Jenny Fauner and Alexis Sullivan from FHI 360 and Dr. Kamara Fantamadi from UNICEF Mali country office. And so that will be the first presentation today. And then we also have Abhishek Hazra from Population Council Consulting in India for the second presentation. So I'll just do a very quick introduction so that we have plenty of time to go through the presentations in detail. And we'll have a Q&A session as usual at the very end. And so our speakers can answer any questions that you have. In the meantime, do feel free to ask your questions in the Q&A box, as Alex mentioned, and we can try to answer things along the way, just in case we don't have time at the end. But I really hope we'll have time for a good discussion period as well. Next slide, please. Oh, and sorry, I just realized I'm not advancing the French slides. That's my bad. Sorry to our Francophone speakers for catching up. Okay, so why does gender matter for immunization? I think we know by now, and I think everyone on this call is now a gender champion as well, that gender does impact immunization, both on the demand side and on the supply side through the provision of health services. And in order to increase coverage and equity, which is ultimately all of our goal as immunization partners and supporting immunization programs, it's necessary to understand and address the many ways in which gender intersects with the way that people access health services and the different socioeconomic, geographic, and cultural factors that also influence this, the ability of access and uptake, and also the way that we deliver vaccine services. Next slide, please. So in the Why Gender Matters IA 2030 guidance document, there are a number of gender responsive approaches to increasing immunization coverage highlighted. And the purpose of this webinar series is to focus on each of these approaches in turn and highlight some concrete country examples of where this is already being applied in practice in the field, because this is constantly a question that we're hearing back from the community. We want more examples of how we can actually put this into place. We understand that these barriers exist, but what can we do to address them, and how can we improve the way that we deliver immunization services to better, improve access to our entire populations? So we've already covered off a number of these in the prior sessions, and as I said, today we're going to focus on civil society and change agents. Next slide, please. So I think it's pretty well accepted and understood that civil society and grassroots organizations can be really powerful allies in delivery of health services in general, particularly in the immunization space. CSOs are really strong and vocal partners in this. And this is true for gender barriers as well, particularly women's groups and girls and youth networks can be really, really powerful allies to help overcome gender barriers and increase access to services. And this is because the civil society actors really have the local expertise, the local context and perspective to be able to bring information and improve access, particularly in marginalized communities. And so involving these groups in the design, the delivery of services also actively takes steps to empower these groups as well. And it's a cycle. And so, we have two really interesting presentations today that highlight particularly where this has been put into place in Mali and in India, and to show how these groups really do have an incredible amount of influence in the communities and can really be leveraged to increase access to health services and uptake in the communities in which they work. Next slide, please. And so just to circle back to the Why Gender Matters guide, as with every other approach outlined in the guide, there's an action list of suggested ways to implement these approaches. I won't go through all of these in detail because I'd rather hear from our speakers, but just to remind everyone to go to the guide and see what some of the examples are that are listed there, and think about how they can be applied in the context in which you work. And I think with that, we are over to Ginny and Alexis for our first presentation.
Thanks, Stephanie. And hi, everyone. We are excited to be here today to present our case study about collaborating with women's groups, a promising approach to identify and reach zero-dose children in urban Mali. Next slide, please. So our agenda for this talk, we'll give a brief background and situate this project in a larger context. We'll go through the case study itself, and then we'll go through the main lessons learned and have a discussion. Alexis and I will be presenting from the FHI 360 side, and we're thrilled to have Dr. Kamara with us, who is based in Mali and was a part of the project. Next slide, please. Okay, so a bit of background. This project was part of a larger project regarding a retrospective evidence synthesis project for pro-equity interventions in immunization, with the thought being that we need to take stock of what's been done thus far so that we can learn how to improve and act on more pro-equity interventions in the future. And so before we undertook the case studies, we conducted rapid literature reviews of selected pro-equity intervention topics, one of which was leveraging women's groups. The results of this literature search are in the form of an evidence brief that can be found on the Gavi Zero Dose Learning Hub website, which is included here in the slide, and we're happy to put it in the chat. And essentially what we'd looked at was define existing studies that looked at either effectiveness or implementation of leveraging or collaborating with women's groups to improve child health outcomes. Although our main focus was on pro-equity interventions for reaching and identifying zero-dose children, we took a broader approach to capture many different child health outcomes for this particular evidence brief. And what we found was that leveraging women's groups is a promising approach to improve child health outcomes and specifically to improve vaccination among under-immunized communities. Implementation considerations, there were many. One that is really important is that context matters and that the more community involvement, support, and community-led interventions tended to work better. And so after we completed this evidence brief, we moved forward and took some of these topics that were promising to identify concrete examples of how they had been implemented in the field. Next slide, please. And so this brought us to our case study approach, and the objectives of this approach were to highlight best practices and lessons learned from promising pro-equity interventions and to indicate what might be required to shift programs toward more pro-equity approaches. All of the case studies that we undertook are retrospective to explore pro-equity approaches that have already happened, used to identify drivers for success and lessons learned, and designed to help guide and adjust policies and programs. Next slide, please. Given the critical importance of integrating the gender perspective into pro-equity immunization programs, we wanted at least one of the case studies to focus on a gender-responsive approach. And it's this case study that we're here to present on today. And as Stephanie mentioned, with all of the approaches that are gender responsive, the one that we are talking about today is empowering and collaborating with civil society and change agents. Next slide, please. And so now I'll turn it over to my colleague Alexis, who will walk us through the case study itself.
Great, thanks, Jenny. So I will be speaking about the specific case study, and I put the links in the chat for both English and French. Next slide, please. So we'll start with some context of why women's groups were explored in Mali specifically. Next slide, please. So despite a brief drop in DTP3 coverage in 2020, Mali has maintained a high level of coverage at 77% since 2017. However, less than 50% of children in Mali receive all essential childhood vaccinations, and rates of under-immunization and zero-dose children vary widely throughout the country, with half of zero-dose children being concentrated in 21% of the country's districts, including those districts in the Sikasso region. And so this case study explored how Mali worked to identify and reach zero-dose children in those urban areas, specifically in Sikasso, by leveraging women's groups as a pro-equity intervention. Next slide, please. So despite recent progress, under-5 mortality does remain high. And like many countries, Mali experienced challenges with health service delivery during COVID-19. There was also a military coup in 2020, as well as ongoing regional conflict and civil unrest. Mali has high gender-based inequities, exemplified by a high maternal mortality rate, gender-based violence, and lower educational attainment among women compared to men. And so within this context, improvements in immunization programming with both a pro-equity and gender transformative focus can be extremely impactful, but also challenging to implement. Sikasso, which is seen in the figure on this slide, is the third largest administrative region in Mali in terms of population and contains 10 health districts. There are many zero-dose and under-vaccinated children living in Sikasso, Notably, there are also many internally displaced populations and migrants in Sikasso that face unique challenges to receiving health services, including immunization. So we wanted to explore how women's groups can help address some of these challenges to vaccinating children in urban. Slide, please. So I'll get into sort of the specifics of what the program of the case study included. Next slide, please. So in this project, women's groups were identified by the local social development department and community health associations to support the urban vaccination strategy in the Sikasso region. The Bamako model was adapted for implementation in Sikasso, specifically within the catchment areas of 11 urban health centers that had the most zero-dose children. Some women's groups did exist in Sikasso before this strategy was created, and other groups were created specifically for this project. In total, 330 members of women's groups were trained as volunteers in Sikasso in communication, home visits, and tracking cases of under-vaccination and zero-dose. Women's groups' primary role in this strategy was awareness raising. So the strategy included 3 home visits each month by each member with 3 main objectives: searching for children lost to follow-up for vaccination, raising awareness regarding vaccination, and identifying malnourished children. Next slide, please. So we'll get into sort of the specific activities that were conducted as part of this project. Next slide, please. Women's groups conducted a variety of activities. So members were provided a list of under-vaccinated children, which were generated using immunization records based on their proximity to the community or their familiarity with families. And vaccinators provided the list of missed children to group members on a weekly basis, and then provided monthly monitoring. Group members were also provided telephone numbers for parents and vaccination vouchers to give to caregivers of children who were missing vaccines. Group members then went door to door in pairs to identify and record under-vaccinated children, as well as provide vaccination information to households. The women also organized sessions to raise awareness about vaccine-related events. Next slide, please. Key informants in our case study reported that women's groups were essential in overcoming challenges to vaccination in urban Mali. For example, it was important to have vaccination services on the weekends so that mothers and caregivers who work during the week still had the opportunity to get their children vaccinated. And women's groups participated in these weekend activities, helping generate demand and support delivery of immunization services. Women's groups also could help compensate for low motivation among healthcare workers. And finally, in some cases, women in households were reluctant to meet with members of the women's groups, as they said they were not health workers and did not trust the messages they were sharing. The program planned to assist trust and visibility by providing all group members with identifying vests. Next slide, please. So the provision of incentives to women's groups was a specific challenge of this approach. Payment was introduced following the Bamako model, in which 2,000 CFA would be paid per woman per home visit. And as the model included 3 home visits per month, the plan was to pay each woman 6,000 CFA per month. However, due to financial constraints, the actual payment was limited to only 1 home visit, or 2,000 CFA, regardless of the actual number of visits conducted. This experience raises some concerns regarding financial incentives and their impact on pro-equity and gender transformative interventions. If incentives had been provided as intended, they could have improved women's economic standing in the community, potentially impacting agency and gender norms. They could have also helped offset any opportunity costs for the women, making their decision to participate more financially viable. However, by not providing the incentives as intended, the intervention could have inadvertently harmed women who may have been expecting the payment. Next slide, please. We found a variety of facilitators and barriers to collaborating with women's groups for immunization purposes in urban Mali. Enablers included leveraging pre-existing groups, deliberate selection and training of group members, and the provision of key resources, such as lists of under-vaccinated children and the identifying pests. Barriers included social and religious factors that can limit women's engagement, large coverage areas, a lack of financial resources, some logistical challenges, and a lack of trust from community members. Next slide, please. So we'll get into some results. Next slide, please. Because this intervention has been implemented for a relatively short time, final results are not yet available. But some initial findings do highlight that leveraging women's groups in Picasso appears to be successful in helping identify and reach under-immunized and zero-dose children with vaccination. And this can be through providing information to families about vaccination and opportunities to vaccinate their children, working with district officials and health systems to identify and record under-immunized and zero-dose children. Some of the key informants also reported that after receiving specific training to recover under-vaccinated children, women's groups helped identify many children lost to follow-up, as well as under-vaccinated and zero-dose children. Next slide, please. In terms of implementation results, there was also evidence that women were more motivated when they were paid incentives for carrying out immunization-related activities, as substantially more home visits were conducted. Additionally, having more engaged communities through leveraging women's groups led to some unexpected positive outcomes, such as an improved outbreak response. Women's groups have proved crucial in responding to a recent outbreak of measles, as they were able to work with community leaders to emphasize the importance of immunization and encourage community members to adhere to vaccine schedules. Next slide, please. And we'll close with some limitations, lessons learned, and solutions. In terms of limitations, women's groups were only one element of the urban immunization strategy, and therefore it was not possible to formally and quantitatively evaluate the direct impact of women's groups alone on vaccination rates, though this was also not the main goal of the case study. Additionally, the methods of this case study approach involved speaking to key informants familiar with the immunization program in Mali, but not group members themselves. Maintaining the local and small-scale nature of women's groups is crucial for their success. External funders, local government, and program managers must ensure that members are adequately trained, as well as genuinely engaged in all aspects of the program, which might include setting priorities, designing and implementing activities, monitoring for results. And this is necessary to improve ownership, sustainability, and impact, as well as address critical gender-related barriers while increasing women's empowerment. Furthermore, enhancing trust among communities of women's groups will facilitate the effectiveness of their activities and their messaging. Programs like this must be implemented within enabling environments, and roles and relationships within health systems should be clearly defined. Group member selection has a substantial impact on performance and should take into account the size of the area to be covered, as well as training needs. Additionally, programs need to carefully consider how providing financial incentives would impact the group and their goals, and whether their approach aligns with the WHO guidance on the rights of community health workers. If financial incentives are being considered, payment mechanisms need to be clear, planned in advance, and with adequate resources, and monitoring and accountability to ensure plans are followed as intended. Next slide, please. To ensure programs are not gender harmful, managers need to be especially attentive and quickly address the risk of groups being instrumentalized for programmatic purposes. When those risks are not adequately addressed, those practices could potentially harm women's autonomy and agency in a community, and avoiding such situations needs to be a programmatic priority. And this applies whether existing groups are leveraged for an intervention or groups are established for that purpose. Next slide, please. Based on these lessons learned, I'll conclude with some scalability considerations. Groups must be maintained and supported at the local level, complemented with technical assistance and training. And before this collaboration with women's groups is replicated in other settings, many topics should be considered, including cost and available resources, the current presence of groups, and community ownership and trust of groups. Next slide, please. Okay, so thank you very much, everyone. I'm now going to pass it over to Dr. Kamara Fantamati, who will speak a little bit more about this project. Thank you.
Before Dr. Kamara starts, I would like to let our Anglophone audience know that he's going to present in French. So to listen to this presentation in English, please go to the globe at the bottom of your Zoom window and select English. Thank you. Dr. Kamara, c'est à vous.
Okay, thank you everyone. I am Dr. Fantamadi Kamara. I'm an administrator for immunization. I work for the UNICEF in Sekasso in Mali, in Western Africa. So as was already said by my colleagues, so women groups in the context of Sekasso were implemented. They are implemented to really improve the current vaccinal situation. So in Sekasso, we have 47 community health centers, which include some in the capital and some regional center. So very regularly, we analyze data. We analyze data monthly. So it was proven that there are more children there are more non-vaccinated children in the city. So which is why with the UNICEF team, we thought, how could we improve that? So we decided to use women's group. We decided to train them in order to really look for children, zero-dose children, or also zero-dose children, but also children who already started vaccination, but did not finish, like you said during the presentation. So this is why 330 members were trained in 11 health centers in the capital, in Sekasso, in order to implement this activity. So these people are trained, and like the presentation already shown, we focused really on the child survival, but also on missed children. So some groups were already existing and already working with health centers to promote health behaviors, but really we focused on missed children, missed dose. So the training first started based on an analysis of a situation. Then we digitized that. We were able to visit lots of homes and to identify the missed children. This is how then we were able to start home visits. Home visits were working 2 by 2, and every pair had to do 3 visits every month. All these visits had follow-up and they are digitized. This work was done every month. So every month we had a look at the situation, and every week also there was a list that was made available to the women groups. And the end of the term, of the quarter, generally we have a review, and before this review we have a supervision. So that means we have 2 levels of supervision. So the community health center and the district health center that's supported by the region and us, the partners. We do quarter supervision, a quarter follow-up, and a data review. So after this data review, we see how the research was led, and we follow indicators. We perform a follow-up of indicators on the platform, which is the only vaccination database in Mali at the moment. So as we said, the groups, they they have some incentives. So 2,000 CFAs that were financed by UNICEF and Gavi, and we had some moments when we did not have funds, which had a bit of an influence on the motivation of the women's group. So we had some difficulties. We encountered a few difficulties in the way they worked, but where we are at the moment, we have some funds. And also, after those home visits, there were some difficulties within the women's group that were linked to the fact that homes did not necessarily trust the group. So this is why we wanted to improve the visibility by buying some vests for the members, but not just the members, but also for the whole team at the district level. So this is really to engage the groups in order to look for the children in Sikasso, which is a process where we need also the implications of the Regional Directory for Health and UNICEF Sikasso and also the Bamako office. So it's a big process that we are currently trying to document. And bit by bit, we are really gaining traction, and it's really contributing to vaccinating children in the region of Sikasso. Over to you.
Vous me recevez?
Oui, merci beaucoup, Dr. Camara. Stéphanie?
Yes, perfect. Thank you. Thank you so much, Dr. Kamama. Merci beaucoup. And now we're over to Abhishek.
Thank you, Stephanie. Good morning, good afternoon, and good evening to all, depending on the place from where you are joining in. Greetings from India. So for the next 12 to 14 minutes, I'll be sharing some learnings based on our bodies of work around women's groups, women's movements, and how they play a catalytic role in empowering communities, in improving immunization and also access to health services. And I'll also give some examples specifically from India. Next, please. So I'll be talking on 5 key aspects. First, I'll give a brief intro about what is women's group, how they function, what are the different types of groups. Then I'll provide a brief landscape of women's groups in terms of its reach, its coverage, these things. And then that is specifically, again, that landscape is specifically for India. Then I'll touch upon different types of interventions that have been experimented engaging women's groups, and what are some key lessons that we can learn or we have learned from these interventions. And finally, I'll conclude with some key takeaways and what are some of the potential way to leverage and engage these women's groups for better health outcomes. Next, please. So what is women's group and how do they work? Primarily, it's a voluntary group that is voluntary group of women who come together for a shared purpose. And the purpose primarily is to kind of do some financial or expand their livelihoods. However, the groups vary in terms of the governance, in terms of the membership, the member size, the purpose, and also the approaches. Broadly, we can see there are 4 different types of women's groups or collectives. One is called self-help groups, where primarily the women are organized for economic empowerment. As I said, they do livelihood activities and try to improve their financial conditions. The second group is more of open and more participatory approach they adopt, and mostly those are for health aspects. The third category of groups are a special population group, and it can be again open group or closed group. For example, in India, there are commercial sex workers group in many parts. So which again, it's a collective, help them in a solidarity, also in improving their bargaining power with customers and clients, etc. The fourth type of group is community-based women's group, where group of members come together, and again the purpose there is broad development objectives. Like for India, self-employed women's association is one classic example of this kind of groups. So these are four different typologies or different types of groups. Next, please. If we look at the landscape of women's, specifically the first category of women's self-help group in India, it's massive. If you look at the scale, more than 9 million of women's self-help group, which is just one of the four different types of women's group that you saw in the previous slide. If you consider all four types of groups, it's more than 13 million of women's groups. And you can see 98 million or more women are part of only one form of which is self-help groups. And all these groups are specifically the self-help groups, they have a federated structure, three layers. And why I want to bring that here is that it really builds and support the collective work that this platform carry out. And now, just to highlight that now these federations are being registered as community-based organizations, CBOs, in India, in some parts of the country. Next, please. So Population Council, we have done tremendous amount of work around women's groups and have a huge body of evidence on women's groups. We have worked studies across 16 states in India around livelihoods, health, nutrition, women's agency, gender-based violence, and linkages to government schemes. We had a study, multi-country study, India, Nigeria, and Uganda, where we tried to, map the different typologies, the effects, and also what are the different approaches that have been adopted in these countries. We also worked closely with UNICEF, Regional Office of South Asia, to examine the pathways to improve women's nutrition and what are some of the potential ways to leverage women's groups, women's organizations in the 8 South Asian countries. Our evaluations have been rigorous. It employs multi-pronged approaches, quantitative process evaluation, need-based studies, and also we have done a thorough systematic review of all the women's group related work. Next, please. So if we look at some of the interventions that have been tested and experimented engaging women's group with an intent to improve health and well-being, they ranges from reproductive, maternal, newborn child health, through nutrition, violence against women, vector-borne diseases, sexual health, and HIV. And if we focus only on immunization, which is part of RMNCH, yes, we note that there is evidence that community mobilization through women's groups helps improve child immunization. Next, please. If we do a deep dive into the immunization to examine how it works or what strategies work, we noted that creating awareness about the importance of complete immunization, because the dropout happens for measles vaccination, especially. So how these kind of groups can be engaged for increasing awareness, also to increase demand for services for immunization and other health services. So in India, there is a fixed day every month. It's called Village Health, Nutrition and Sanitation Day, where the community health workers come to a particular place in a village and aim to provide health and nutrition services to pregnant women, lactating women, and children under age 5. So these self-help groups spread that awareness, and also not only that, make these VHNDs, VHSNDs, or these fixed days that they are being conducted regularly. Not only that, they also encourage and accompany these women and children to those facilities so that they avail the services. There are also instances that the self-help group women, they also prepare a list or just take a note of any pregnant women or any women who just delivered a baby recently, and share that information with the community health worker so that in the community as a whole, nobody gets missed. There are also instances where the members from self-help groups make joint home visits along with the community health workers so that there is greater emphasis of information dissemination. Next, please. In the recent past, especially during the COVID, and we all know how COVID-19 pandemic had disrupted the delivery of essential health services in general, and specifically maternal child health and nutrition services were affected heavily. Very recently, last year, actually, me and my colleague, we published a paper where we tried to highlight how these women's groups acted as a bridge over the troubled water during that COVID pandemic, and also, helped in COVID vaccination. So we defined that they provided three support or complemented the government efforts to mitigate the risk through three-year response that we say. It's relief from the socioeconomic and health impacts of the pandemic. It's resilience against the overburdened and overstretched health infrastructure, and also recovery from the pandemic-induced disruptions in maternal and child health services. And all of these helped the community in contact tracing. They provided information about the virus. They provided information about COVID-appropriate behaviors. They also did a lot of work like stitching and distributing masks, promoting community kitchens to provide food for pregnant and lactating women. And also they played critical role and crucial role in COVID vaccination, especially for busting myths through their collective community mobilization approach. Next, please. There are also other examples of health interventions layered through these women's groups. And one example I'll give from one state of India, which is Bihar, that they adopted, again, a multi-pronged approach where the primary focus was to improve women's level of awareness. And they used multiple touch points. They had discussion around health and nutrition, and of course, child immunization was one key component of that. In meetings, in group meetings, they also had home visits. They also had other community outreach activities, through which they wanted to break the social hierarchy, social norms, gender norms, and other associated barriers. They also had specific focus to strengthen the linkage with frontline health workers so that the supply of services is met, because it's unfair that you only create demand but you don't do anything to meet the supply. So there was also focus on that. Next, please. So when we assessed whether these interventions were effective or not, or how are these interventions effective, we found certainly program participation was positively associated with the correct practices. We also found that these groups, self-help groups, which I have written as SHG, self-help groups, women's groups, they complement the community health workers' effort. And this is the slide, the table you can see, where women received information from self-help groups as well as community health workers both. The chances or the likelihood of women's correct practices is manifold, right? And also we found that participation in these kind of interventions where women come together for multiple activities also help increase the members' agency over time. Next slide, please. And this is depicted through this to this slide, where you can see the the second set of bars of member, where I have written member, means they are the members of the self-help groups. Their level of empowerment in terms of their resources, their agency, their achievement, they have improved, be it their decision-making power, their freedom for mobility, their financial autonomy, or their self-esteem. They have significantly improved because they are coming out of their home and participating in various activities. Next slide, please. So, in summary, what are some of the key takeaways? We note that health behavior change communication interventions certainly improves women's knowledge about correct health practices, and also improves their position in terms of their decision making and mobility. However, having said that, as I said in a recent paper, we made it clear that it's not so easy to improve complex behavior like child immunization. When I say why I'm saying it's a complex behavior, because it's not a one-time behavior. To ensure a child is completely vaccinated, you need repetitive messages, you need follow-up, you need to kind of have mechanism to convince parents and community about any myths and misconceptions. Also, you need to provide support. So a lot of things are related for such difficult behaviors like immunization. So a multi-pronged approach is certainly important. And whenever any intervention is being adopted, you have to ensure that the program has sufficient intensity and is reaching to the intended audience. The last point I want to make is certainly there is scope to expand experiments in similar settings to leverage such organizations, such groups, and because the power of community mobilization is huge. It has potential to break social and gender barriers. And also we should design interventions building on what works rather than experimenting. There is a lot in the published domain, what works and for whom. So we should learn from there and build on, not start from the scratch. Next, please. So these are just a list of resources I thought I should put that our colleagues from Population Council have published in the recent past. You can search for them, and huge body of evidence exists on how these women's group can be leveraged for various health and nutrition related outcome, improving health and nutrition outcomes. Next, please. So I think this is my last slide, but I would like to really thank all of you for listening to me, and special thanks to WHO, Stephanie and Michaela, and UNICEF, Anuradha and Veronica for giving us this opportunity to share our work and learnings with all of you. With that, I am handing back to Stephanie.
Thank you. Thank you so much, Abhishek. Thank you, Ginny and Alexis and Dr. Kamara for these super interesting and rich presentations. We still have time for questions, so we're on a good track. And I see that there have been a few questions already posed in the chat box and that have been answered, but there's still time. So please, if you have additional questions, please put them in the chat and we can answer them live. In the meantime, there is one question still that has not been responded to, and I believe it's directed to Dr. Kamara. But whoever asked the question, if I'm wrong and it's directed to, but I suppose we can turn it over to Dr. Kamara and Ginny and Alexis to answer as it relates to the project in Mali. How was the coverage population per each woman volunteer? So I guess what was the coverage per their sector, and how were the security issues addressed? There's also a question around record keeping issues. So how were these addressed in order to track the vaccinated and avoid restarting due to lost vaccination records, for example?
Yeah, thank you, Stephanie. I think Dr. Kamara has answered these in the chat box.
Oh,
he has answered them in French, so I'm happy to try and translate them. But I think he's best
Je
placed
peux?
to answer.
Oh,
Je peux?
oui.
OK.
Bien sûr,
Merci
continue.
pour les questions, même si c'est en anglais. Pour la première question, comment se fait la répartition, la couverture en fonction des membres des groupements? Donc, généralement, l'équipe du CESCOM fait une répartition de telle sorte que là où les membres des groupements sont proches, les binômes puissent couvrir ces secteurs-là. Parce que c'est en ville ici et la ville est divisée soit en quartier ou bien en secteur. Donc, comme c'est un travail de bénévolat, si plus c'est loin, plus la recette devient difficile. Donc, ils couvrent les secteurs, ils sont répartis en fonction des secteurs comme tels, mais ils peuvent s'entraider parce qu'ils ont même des groupes WhatsApp entre eux et lorsque la liste des enfants manqués est disponible, on peut même partager sur les groupes WhatsApp. Comme ça, le groupement qui est dans un secteur qui n'est pas le leur peut intervenir. Donc, c'est comme ça, la couverture s'est faite. Et de façon continuelle, la mise à jour s'est fait, même des groupements s'est fait pour vraiment que la situation s'améliore tous les jours. Donc, nous sommes à cette phase actuellement. Les groupements sont en train de... sinon les centres de santé sont en train de faire de telle sorte que vraiment les groupements soient plus actifs. Maintenant, la deuxième question par rapport à la question de sécurité, je ne sais pas si j'ai compris. En ville, pour le contexte des groupements, c'est typiquement en ville ici. Donc, j'avais mis dans le chat que il n'y a pas de problème de sécurité lié tout de suite à la vaccination, à moins que je n'ai pas compris la question. Maintenant, comment le problème de tenue des registres ont été résolus pour assurer le suivi? Donc, comme je l'ai dit, c'est vraiment un mécanisme. Généralement, la liste remise au groupement vient des registres de vaccination. Donc, dès qu'un enfant manque, la liste est retracée et remise aux membres des groupements. Donc, dans le PEV dans la vaccination du Mali, il y a un support aussi qu'on appelle les fiches essentielles. Donc, c'est ces fiches-là qui permettent le suivi vraiment de la vaccination des enfants. Et chaque CESCOM chaque centre de santé dispose des fiches essentielles. Et normalement, chaque fois qu'un enfant est enregistré dans le registre de vaccination, il est aussi enregistré dans les fiches essentielles qui permet de suivre à chaque séance combien on manquait et ça aide considérablement dans la recherche active. Je ne sais pas, c'est à peu près ces questions que j'avais pu enregistrer et que, comment on appelle, Alexis m'avait aussi transféré en inbox. C'est les éléments de réponse que je peux donner pour le moment. À vous.
Merci pour c'était très comprehensive. And if there's any further questions on those points to Dr. Kamara, then please put them in the chat. In the meantime, we do have a question for Abhishek on the study in India, or in the project in India rather, around motivation. And so I think, oh, it just disappeared. I don't know if that means it was answered. Oh yes, Abhishek, would you mind answering this live so other people can hear as well, on increasing the motivation without direct incentives?
Yes, so thank you for that question. I just answered it, typed my answer, but I can voice over. So typically, the peer educators who are also from the self-help group, who are also self-help group members, they first receive training on these health and nutrition, behavior change, communication messages, and they receive some incentives for the activities that they carry out. For example, for participating in meetings and delivering information on health and nutrition, doing home visits, conducting demonstration events or community outreach activities. So yes, there is some small incentive that they receive, and collectively the whole platform, you saw that 3-tier platform, there is provision of finance from the system. When I say system, it's from the Ministry of Rural Development, for each platform to receive some money, not for the health and nutrition, But over time, like, that's also a key focus that's happening. But for increasing their livelihood opportunities, they receive, money in various, in terms of various funds.
Thank you. I think we have time for one more question. Peter has asked, and I'm curious about this as well, regarding the Mali interventions, was this a response to a particular gender-related barrier that was identified? And so by that, it'd be interesting to know, was there a gender assessment that preceded the design of this project, or what was the impetus for bringing this forward? So this could be a question again, maybe to Ginny, Alexis, or to Dr. Kamara, whoever wants to take it.
Dr. Kamara, would you like to take this one as well?
Pardon? Pardon, est-ce qu'on peut reprendre la question pour moi en français?
Oh, en français, this is going to be challenging for me. Okay. Est-ce qu'il y avait un assessment ou chose comme ça pour identifier les barrières du genre avant désigner l'intervention en Mali?
Avant
S'il y avait une évaluation. S'il y avait une évaluation avant de faire l'intervention au Mali, est-ce qu'il y avait une évaluation sur le genre?
Ah, ok. Bon, et dans le contexte, nous...
Okay, within this context, it's a regional context for us. So this is the third region of Mali where there's a UNICEF office, which is supported by Gavi. But things are being done at the national level. So there was an analysis, equity analysis that was performed in 2017. To my knowledge, in Mali, the gender issue when it comes to vaccination is not really something. Well, we did analysis regarding equity really in 2017 that exists. And that actually motivated an approach in 11 districts for child vaccination. So we also did a basis analysis at the local level that's more adapted to our framework. But gender is not normally. It's not. I'm just talking about the documentations here. It's normally not something that's linked to vaccination in Mali. So what we did is we asked questions within the homes. We performed an inquiry, a survey of people who take care of children, and usually people who take care of children, which notice during the survey, are usually the women. So we also did surveys in community health centers, and there also. Well, we did not manage that though. There were 9 focus groups with mothers and 2 focus groups with fathers. So we can say, why didn't we do 50-50? Why to take gender into account? Well, I think in our equity analysis that we did in 2017 in Mali, and gender, well, gender is important for everything, yes, and women have a lot of importance when it comes to children healthcare. But in the context in Mali, often is the women. So, I mean, this is what I can add for Mali.
Okay, thank you. That actually was really helpful context. Absolutely helpful. So thank you for that. We really have 2 minutes left, so I don't know if we can squeeze in one more question. Maybe something back to Abhishek on the India study. If we have any others. We do have a question around, is there any studies quantifying the conversion rate of immunization campaigns supported by women's groups? So this is a really good question. I know that there were quite a lot of resources posted at the end of your presentation, Abhishek, but are you aware of any studies that actually measured the impact of using women's groups to support immunization campaigns in particular?
I can't think of any study that assessed the immunization campaign, but there are studies which assessed how information provision through this kind of women's groups and community mobilization helped improve child's immunization. So there are studies assessing effectiveness of those kind of specific interventions engaging women's groups, but not for the government campaigns, how they are useful.
Okay, great. So it looks like there's room for implementation research for all of us to take forward, but learning from other programs is always very beneficial and transferable to the immunization context in many cases. Okay, so we're at the end of the hour, and I know that we're going to lose Emily, our interpreter, now. So let's close this webinar for now. And of course, if you have any further questions, feel free to share by email or through the TechNet forum. Again, everything is available here on this TechNet webpage. All the previous recordings and this recording will be sent around to you all, and will also be available on that page very shortly. Please do join us again for the next webinar in 1 month's time. Continue to share among your networks, and we look forward to seeing you again soon. Another big thank you to the TechNet support team, Alex and everyone else at TechNet, and to Michaela Manna for helping coordinate these webinars with me at WHO. Over to you, Alex, for anything else, or we can close out.
You said everything, so we can close.
Bye,
Bye, everyone.
Bye, everyone.
Yeah, bye, everyone. We'll send you the links by email. Everything will be available. Bye.
Thanks.
Thank you again to our presenters too. Sorry, I meant to say that.
Thanks.
Thank you all. Have a great day.